today we are really privileged to have Professor Dinesh Bhugra, who is Professor of Mental Health and Cultural Diversity at Institute of Psychiatry, King's College, London. For me, I have known Dinesh for a long time. He has been supporter and contributed to workshops with UK Asian Film Festival on mental health and films, and also talked about how mental health is portrayed in Hindi cinema. In this COVID time, when mental health is such a big issue, we thought it was an opportune time to invite Dr. Bhugra here to talk about how COVID times is impacting on everybody's mental health. And we are all looking to Boris Johnson to let us be out of this lockdown. But I would like you to reflect for 1 minute. This is a micro kind of lockdown, but each and every one of us has a little macro lockdown, may it be our religion, our beliefs, superstition, or just fears. So it is a good time to talk. Once we do get out of this bigger lockdown, how do we keep our mental health on personal level and look after it? So today's film, 15 Park Avenue, if you haven't seen it, is still okay to join in with the conversation. Basically, the story portrays a protagonist with mental health, mental illness, schizophrenia in this case. More importantly, the narratives then take us through what this mental illness means to the patient and the family members who are the carers and who had been a part of their lives as she grew up and developed the more severe symptoms of this illness due to an incident, and also shed light on cultural norms, relationships, anxieties, and restrictions that the family members are going through. So I'll pass you on to Dr. Bhugra. Thank you.
Thanks very much, Pushpinder. Thank you very much, Aman, and really wonderful to be here this afternoon. I did my basic medical degree in India, and then I came over to train in psychiatry and kind of stayed on. And for me, I think one of the big challenges of mental health is in terms of subspecialty of medicine. I think psychiatry is the best branch because you incorporate biological, psychological, social factors, and spiritual and anthropological, etc. So try and make sense. In the next sort of 10 minutes or so, I'm going to talk a bit about what we mean by mental health and what we mean by mental illness and what are the differences. And I'm not going to try and cover an encyclopedia of 500 odd mental illnesses in that time. But just to highlight that roughly, there are 3 areas which we would consider causing mental illnesses. Firstly, I think we need to bear in mind that cultures see mental illness and mental health in very different ways, and we need to be very cognizant of that. And particularly, South Asian cultures have a different way of looking at things and how people explain what is going on and what the challenges and what is normal, what's deviant, what is abnormal, and where do people seek help from, and how do they see their experiences. So by and large, there are kind of areas which affect mental illnesses are in our thinking, in our mood, and in our behavior. Thinking is about, and I think one of the big challenges in thinking is that at this point, I'm talking to you all, but you have absolutely no idea what I'm thinking. So I can withhold what I'm thinking depending upon how confident I am and what my external boundaries are and how I convey that to you, what language I use, what terms I use, what words I use. And those are all determined by the culture and society and what's normal and what's abnormal. But equally, we all have good days and we all have bad days. And sometimes you say, well, I got out of the wrong side of the bed because you're feeling low and you're feeling tired. And that's not mental illness. I mean, that's just, I think one of the dangers quite often in medicine and generally, particularly across many cultures, is that we tend to medicalize normal human emotions and normal human responses. And one of the things that I have seen in the last year or so, particularly post in the kind of pandemic, lots of people talk about stress, but a lot of them also talk about post-traumatic stress disorder. But I think that there is a kind of challenge in what's a diagnosis and what are the normal experiences, and we need to bear that in mind. One of the big issues that we need to be thinking about is mental illness versus mental health. And are we saying that mental illness is part of the same spectrum, that on one end you have mental health and on the other you have mental illness? And one of the, again, points that we need to clarify is, for example, if you have diabetes, does that mean that you're ill all the time, even when your diabetes is under control? Or you're ill, physically ill all the time? And similarly, if you have a bipolar illness, which means that you have mania sometimes or depression, and then you get normal and then mood swings change again, does that mean that you're always ill? And I think that's a debate we need to have. And mental health is partly to do with things like mental functioning. And again, there is a sort of range, at one end of the spectrum, you get dementia. You can't think clearly, or your memory gets short. You can remember distant past, but not immediate past. And, what does that say? Mental health is also about leading to productive activities. Now, again, I have a problem with that definition. The productive for whom? For me, for my family, for my friends, for society, or something else? And again, that's something that we need to be thinking about. It's also, mental health is about having fulfilling relationships. And fulfilling for whom? For me or for others? And again, I mean, that reflects, and I'll come back to the COVID challenge, as Pushpinder highlighted, that fulfilling relationships for whom? And it's also, mental health is also about our ability to adapt to change. And, again, being locked down, being in isolation, being in shielding, we have managed to adapt. I would be having this conversation in front of you at, in Piccadilly, at BAFTA, or in SOAS, as Pushpinder had organized in the past, or elsewhere, seeing the film and then having a Q&A. But, we've kind of adapted to this. So one of the big questions for us is, how do we define mental health, and how do we define mental illness, and how do cultures see mental illness? And once we've decided, if I am feeling unwell, I feel stressed, I feel distressed, I feel anxious, I feel depressed, how do I then see that as a problem? And what's my explanation for that? And what anthropologists call explanatory models. And if I see that something has caused my problem. It's an evil eye, that my neighbor has caused an evil eye, or is it something I have done? I did not do the proper ceremonies to uh, towards my elders or whatever, and I'm being punished? Or do I see this as a medical problem, that it's a vitamin D deficiency, or something else, or it's a psychological cause because of the stress and life events and what that has done to us? And that would determine where I seek help from, who's the first person I contact. And studies have shown that vast majority of medical and psychiatric conditions often get treated in personal, folk, or social sectors. So I want you to sort of think about the last time any of you had a headache. What went through your mind? Was it migraine? Had you had migraine before? Did you feel that it was stress? Did you feel that it was partly to do with drinking too much or not drinking enough, or dehydration, or start of flu? And then, depending upon how you saw the headache, you would say, well, okay, I've had a headache before. This is the headache now, and I need to take aspirin rather than paracetamol because aspirin works better for me. Some of you may feel that it's ibuprofen works better rather than aspirin or paracetamol. So depending upon your previous experiences, you would take treatment or seek, and I'm talking about headache here. Similarly, if you feel anxious because you're worried about your exam results, or you're worried about travel, or you're worried about something else, you're worried about financial situations, you may feel somehow that, okay, this is anxiety, what do I do? And again, there is a difference between the way we as doctors see mental illnesses and the way the community does. For us, it's a disease. It's literally dis-ease. It's about pathologies, trying to understand what's going on. And whereas the patient who is experiencing those symptoms, it's about them not getting a job, not having a home to live in, not having difficulties in forming relationships. And that's where disease becomes an illness. And patients are much more interested in illness, and we are much more interested in diseases. Now, if we look back at 15 Park Avenue, for me, I think it's the most impressive thing about this film is the impact it has on carers, the impact it has on the families. We see patients for half an hour every week, every 2 weeks, every 3 months. But rest of the time, the families are looking after people with mental illness, with any illness. And largely, it's women who are looking after, and that's very clear from Shabana Azmi's performance, that her career is on hold, and she can't have an emotional relationship because she's dedicated to her sister's welfare. Mother is kind of bewildered most of the time, and this whole sense that, or maybe Nidhi is possessed, so let's have an exorcist come and do exorcism, and maybe that would get better. And the challenges related to sort of life events that Nidhi has gone through, even though the illness started before, the rape and those kind of life events, and then a life event that, engagement breaking down, has a massive impact. And one of the points that we need to bear in mind is quite often life events contribute to stress and distress, and depends upon how we respond to that. one of the things that sort of strikes me about the film, particularly, and not to labor the point, that the impact and how different members of the family see. So brother and his family have kind of withdrawn, although he appears after, in the hospital and offers to pay 25,000 rupees towards the hospital cost. But it's also fascinating to watch that the doctors are interested in investigations. They're interested in doing scans to find a pathology. Whereas, the sister and the mother are trying to sort of say, well, okay, if we get her married off, will that help or not? And again, it's a very sort of human response to stress and distress. Treatment, I mean, she's getting treatment and she gets medication and she gets, engagement with the psychiatrist. But it is important to recognize that what they're showing is a kind of dramatic form of schizophrenia. And when the father says to ex-fiance Rahul Bose and that character that, she will never get better. And that's a misperception. 33% of patients with schizophrenia will get better no matter what we do or don't. 33% would get better with medication and support and counseling and other things. So it's about 1/3 who may have problems. And generally, again, females who have schizophrenia generally tend to have a better prognosis. So I'm not going to sort of say that, film has the wrong portrayal. It is quite a sympathetic portrayal. And for me, I think one of the stunning things is the ending, which is ambiguity. It's ambiguous. And what happened to her? Where did she disappear to? And one of the big things in psychiatry is that we as psychiatrists are dealing with that kind of ambiguity all the time. And as I said, that quite often, we don't know, what patients are thinking. We just rely on what the patients express. And, you can control either language or your verbs or your words or your explanations, and you give us the information that you think we want to hear. So I think for me, this kind of film illustrates a lot of positives about how families cope with mental illness and how they respond when your loved one is, kind of struggling. And in India in the 50s and 60s, asylums had the biggest sway. And, if you were going to be admitted to an asylum or a psychiatric ward, a general expectation was that one of the family members, one of the relatives would be admitted with the patient. And that had a number of advantages because it trained you to, it kind of warned about learning the side effects of the medication, about the warning signs of relapse, and it kind of destigmatized. But as the country has changed and, it's become much more of a culture in transition, people don't have the time. And, quite often, relatives may stay, but, occasionally may stay at the night, but not 24 hours a day. So the kind of whole response to mental illnesses has changed. And I think I'm going to sort of stop there. I've gone on a bit longer than I had planned to, but I'm very happy to take questions generally on mental health, mental illnesses, and related to the film in particular. Once again, thank you very much for tuning in, and thanks very much for inviting me.
Thank you for that talk, Dr. Bhugra. I was just wondering, because I can relate to some of the things that you were saying, cures for headaches. I had, when I was suffering from my anxiety, I had similar things. What I want to ask is, do you think we've progressed so much more now with mental illness recognition, or is it still the same thing where the doctors are still looking for a physical sign? For example, I've been suffering for a long time. I had migraine headaches to go through. I had to look at, the doctor thought I had IBS because my stomach was constantly aching and I couldn't. Then I had problems with sleeping, so I was given sleeping tablets. So I've had all of those things. And it's only once I got to the stage a couple of years back that I suddenly realized that it is all to do with something that happened to me quite a while back.
We are learning more and more about the brain, and we're learning more and more about the structures of the brain and the functions of the brain. And we're learning, I think the big shift has been that we now know more about various illnesses and the genesis. And let me just very quickly give you an example, and then I'll come back to something else. We now know that, attachment patterns that children have with their parents in childhood. Psychoanalysts talked about it in the 1940s and 1950s. And now we know that those patterns affect brain structures of the children, and they then affect the brain functioning. So it kind of starts off at a very early age. And we also know that 50% of psychiatric disorders in adulthood start below the age of 15, and 75% start below the age of 24. So we need to kind of understand in a much more developmental way. The second point, and I think that's the point that you're making, is that it is really a tragedy that in Western psychiatry, we kind of separate mind and body as if they don't talk to each other. It's sort of Descartes' theory of mind-body dualism. And, if you look at Ayurveda and you look at the Chinese system and you look at the Greek system, mind affects body, affects mind, and these are affected by things like diet and environment and relationships and so on and so forth. So I think one of the challenges is that we need to bring mind and body together. That, if you have diabetes and you become depressed, it's important to treat both rather than just focusing on diabetes or depression. Because we know that, quite often, people present with physical problems even when they're feeling stressed and distressed. You may develop stomach aches, you may have constipation, you may have, poor concentration. So the important thing really is to integrate the brain and mind on the one hand and body on the other, kind of functioning together, making it a much more coherent, mutually linked approach. And I think more and more people are beginning to realize, and again, I think one of the big changes in psychiatry in the last 20 years or so is looking at spirituality and, faith and how that affects, and, how we try and deal with that. And again, I think an interesting example from Gujarat is that there is a dargah where people with mental illness used to go and pray. So the Gujarat government spent about 2 years working with religious healers and, people in the dargah to set up a psychiatry clinic. So you then had a sort of psychiatrist and a nurse and a pharmacist there. And now when you go to the dargah, nobody knows whether you're going to pray because you have mental illness or you're going to see a psychiatrist. So once you go in, you're seen by the psychiatrist and he or she prescribe medication. The pharmacist dishes it out, but they don't give it to you. They give it to the religious leader who gives it to you saying this has been blessed by the Baba. And so the compliance has increased. So I think to me, what that illustrates is bringing together in psychiatry the kind of Western model with the local perceptions and working together in a way, not only integrating mind and body, but also integrating folk and religious cultures on the one hand and medical culture on the other. So again, I mean, I think one of the big challenges in this country is that we need to bring primary care and secondary care together. We need to bring physical and mental health care together, and we need to bring social care and healthcare together. Does that kind of answer your question?
Yes, thank you. That's brilliant. Thank you.
Hi, Sadia, you've got a question. You've got your hand up. Would you like to unmute yourself? Thank
Yes, you. Hi. Thank you. That was fascinating, Prof. Bhugra. I really enjoyed that. Thank you so much. So when you were speaking, I was really struck by what you said about, this idea of medicalizing what's normal, and sort of, the effects of stress and that we're all facing currently. I work in a CAM service, and this is something really I've been trying to kind of communicate with families, that, it's been an extremely stressful year, and it's going to take it's taken its toll on everybody. Yeah, and obviously we, a lot of our young people are very vulnerable. The families are vulnerable, but there is still that difference between what is, I suppose, normal and to be expected, and what kind of shifts more into then something that you need to see as, a medical deterioration and something that requires input. But I found those kind of discussions can be quite difficult at times. There can be a resistance to accepting that by the families, by, even the system, I guess, around them. And I just wondered if you had some advice around that. How can we help, in changing that narrative, or, just helping to, acceptance, I suppose, of that normalizing of stress, to an extent.
Yeah, I mean, I think it's a very interesting point. I mean, one of the things that worries me that we've gone into, the society has gone into a kind of framework where, you can't be anxious, or you can't feel low, or you can't be having a bad day. It has to be a medical problem, and somebody else has to sort of sort it out. And yes, at the same time, I think there is also, I mean, my challenge has always been when I see patients is, what do you think is wrong with you? And then you try and kind of reframe what they feel is wrong and what you can and what you cannot do. And let me give you an example. I mean, I think many years ago, I had been seeing a patient for a number of years, fairly similar to the portrayal in the film. And I got a phone call from the father of the patient and said, can we come and see you? I said, fine. We arranged a family meeting, and they said, I understand that you've been prescribing this medication and it seems to be working, and the patient is fine, but we feel he's possessed, and we want it, exorcism. What do you think? So my response was that, okay, what makes you think that? How do we sort of engage? And we agreed that, as long as they don't stop the medication, it's fine by me, as to what their explanation was. And they said, no, we were not thinking of stopping the medication. That's fine, we understand. But, can you recommend an exorcist? And for me, that was the sort of killer question, because I don't know any exorcists. So I basically put them in touch with the hospital chaplain, and, to date, I don't know what went on. But as far as I was concerned, the patient remained engaged with the services. Last I heard, they'd got married, had 2 children. So for me, I mean, that was kind of, one extreme of things. And similarly, there was somebody else was telling me a story about a Nigerian patient who had schizophrenia, and the family brought a Nigerian shaman, and they sort of, the shaman was obviously quite good at that. And he said, you're suffering from 2 conditions. One is a Nigerian one, and one is a Western one. So the Nigerian one I can deal with. But the Western one, you need to see, Dr. So-and-so and have that treatment, whatever they prescribe. So you can bring those things together. And I think at the same time, we need to be cautious that we don't undermine the parents or the patient by saying, this is not serious, go away, stop bothering me. Because you have to get that balance right, that, it's a problem for them to try and understand what makes it a problem. And is it simply that, the child or the young person is expressing distress on behalf of the family? Or there is a genuine issue, and part of the, the kind of, who's the ill person here? Is it a normal response to stress? And, part of my anxiety has been that, increasingly people are now talking about, being cooped up causes post-traumatic stress disorder. Does it? So if we look at the diagnostic criteria by statistical manuals, then probably not. But, if the person is feeling stressed, we need to find out what's going on. I mean, does that kind of help clear things?
Yes, no, that's really helpful. That's really helpful. Sorry, I was just when you were saying about the, the idea of like being, being sort of isolated at home sort of increases PTSD symptoms. I think is it true that maybe if you've got a history of domestic violence or things that have happened, in the house, that those can be reactivated then because of the the lockdown restrictions?
I think there is absolutely no doubt. There's clear evidence that you can have flashbacks, and certainly the rates of domestic, interpersonal, sexual violence and abuse have gone up in the lockdown. I mean, there's no doubt. And I think one of the big challenges really for South Asian communities that we don't talk about those things. There is a question of shame. There's a question of stigma. There's a question of bringing dishonor to the family. And I think the point is that we need to be able to provide safe spaces for people to sort of talk about these things. And it's not a question of shame. And it is a reality. And if it's causing a problem, then we need to do something about it.
Thank you. Okay, I think we'll go to Saraswati. I think she asked first, and then we'll go to Alina and then Rakhee. So Saraswati, if you want to ask your question, it's Dr. Saraswati Hosdurga.
Yeah, thank you. It's been an excellent discussion here, first of all. I got two things to ask to Doctor. One is, in this movie, 15 Park Avenue, I know the ending, it is so ambiguous and really don't know what happened. If you turn the clock back and if we ask, what would be the way you would end it?
Well, I mean, I think the question, it's absolutely fascinating, because one of the things that kind of struck me as I was watching it, it's about what's reality and whose reality we are talking about. And I think that's part of the challenge for psychiatry and patients with mental illnesses, because what's real for me may not be real for you. And that's where culture comes in, and cultures define what's deviant and what's abnormal and what's not. And therefore, I mean, I think that for me, that challenge of defining reality is the crux of the film. That she's going through all that and she's convinced that there is a kind of 15 Park Avenue here, and it's something to do with Saddam. And that kind of delusion, that reality, how do I know that, your reality is the same as mine? And part of that clinical interaction, and I think certainly the psychiatrist is much more sympathetic than we see in the beginning. So he's much more aware, and he kind of raises some of the questions. So I think in I mean, you know, I would think that that was the right way to end the film. But the ambiguity there is what happens to her. Did she kill herself? And if she did, how does the family cope with it? Because family are bewildered because they don't know what's going on. Nobody's told them that your reality versus her reality. And for me, it's also about the internal space that all of us have, which is safe space that we sort of go into, particularly when we are threatened. And it's also about the kind of not inward looking in that kind of in a negative sense, but forming the safe spaces. And that's the critical bit in child rearing. And going back to this kind of almost sort of responding to Sadia's point that when we are growing up, we learn, you know, culture teaches us how to look at the world, who are the bad guys and who are the good guys, and, you know, who to trust and who not to trust. So part of that, I mean, what mental illness is, I mean, this is extreme example of schizophrenia, which is, you know, less than 1% of the population, but it can be fairly severe. And it is about that delusion, and it's about those hallucination, and it's about the reality. So I think in a, I mean, in a way, I think that was the most appropriate ending. Any other way that, you know, she recovers completely, yes, you know, that would have been fine. But it also kind of illustrates the ups and downs in her life. Would having married Rahul Bose and, you know, being in love made it different? Who knows? But the fact that he is with her at the end, kind of, you know, there's a male figure she can trust after the sort of multiple rapes. So that again sort of illustrates a kind of gender equity. So I'm just sort of, I can go on, but I'm going to stop there.
No, only thing is, like, you know, when they when the whole family cared for her and looked after her, leaving that and then they being, you know, accepting and moving on was then slightly kind of a difficult to comprehend. Like, you know, they have vetted, I mean, so much of time and efforts given in caring and looking after her, and she suddenly disappears and everyone just turns back and then goes. So that's what I was kind of trying to find slightly difficult.
No, I mean, I think in a way, to me, that also reflects the unrewarding nature of all the work that carers do. You know, you get no reward and you get blamed. And, you know, there's that wonderful scene between Shabana Azmi and Wahida Rahman, and Shabana is getting sort of irritated with mother, and then, you know, the mother bursts into tears. And it may be that, you know, the mother is also feeling guilty that I've given birth to somebody who's not normal in that sense. So in a way, it's kind of, to me, it sort of reflects the unrewarding nature that the carers put up 24 hours a day.
That's brilliant. Yeah. Thank you. That's brilliant.
Thank you. Okay, we'll go over to Dr. Alina Mirza, please. Alina's part of our UCAF team in Scotland. If you'd like to turn your mic on and ask your question, Alina.
Good afternoon, Dr. Bhugra, and it's been great to be part of this conversation. I actually have, I would say, a question or comment. One was in terms of when you were talking about, and when we talk about what is health, and in terms of health, one of the things over time, what I felt was, you know, we have the broad definition, it's the physical, mental, emotional, social well-being. But also during my work, I've sort of and part of it, which UK Asian Film Festival does as well, to that it's to be able to fulfill one's creative potential. And that is part of health and well-being. In terms of your work, how would you see that in terms of, we might have children growing up and in certain, maybe, I wouldn't say faith groups, in certain environments, they don't have an opportunity, or what they would be showing as their creative potential. And I'm saying that in terms of everybody has a creativity in them. Not everyone is going to become a musician or, you know, a full-fledged writer, but we all have certain creative talents to our within our personality. So in terms of mental health, if people are not able to fulfill or engage in that creative potential, how does that impact, and especially within South Asian communities, where involvement in the arts used to be frowned upon, still frowned upon in terms of people taking it as a career choice. So that was one aspect I was going to sort of ask you. And one other question was that I know your book came out, but since then, do you think you might write another chapter, you know, of what has been shown in Indian cinema, and maybe not just Bollywood, because I know there are films from South Indian films, which Karnataka and other, which have looked at, or which where there are issues in terms of mental health have been covered. So do you think you will write a sort of a updated version of Mad Tales from Bollywood in terms of the last 10 years? I think that would be quite good, because there are films which have come out and looking at different issues, whether it's mental, stigma associated with mental illness, or even talking about mental health per se. And the third thing I was going to ask was, and I think it was very interesting when you mentioned about the Dargah in Gujarat, and how they have set up the mental health, patients, a sort of multi-purpose center where there is a doctor as well as a pharmacist and nurse. From my experience, and this is a long time back, I'm talking about 30 years back, and working in Pakistan, and at that time I was doing my house job, was with Dr. Malik Mubashir's unit in psychiatry. And one of the projects they did was, and like you were talking about, the role of the peer in the community. From Pakistan or India's perspective, of course, there is a place for peers, because people don't have access to health services, whether they're villages or small towns. So in terms of mental health, that's even less as compared to, general physician or other health services. So the peers provide that spiritual, fulfill that spiritual gap or the mental health needs of certain communities. And therefore, the Dr. Mubashir has recognized that need. So he worked with a peer, and apart from other sort of health education projects, worked with the peer and gave them some training in identification of mental health diseases, which were the four main ones: schizophrenia, depression, manic depression, and asked them that they wanted him to act as the sort of middle person, and that they didn't want his, as they say, livelihood to be affected. But if he recognizes someone with these symptoms, then they would try and help and refer them to the psychiatric unit. And the peer did collaborate, and that's how then the patients used to be referred. Now that's a model which could be used, like you are saying, the model in Gujarat, which could be used, and the peers or spiritual healers could be brought on board. But in UK, there isn't issue with access to services per se, and therefore there are we see a lot of ads, especially I saw in London, about peers who have moved from India or Pakistan and offering spiritual healing. So within the context of, I understand that, we have to look at models of health where, the patient is looked in a more holistic manner, maybe towards social model of health, but also where certain, the peers can be charlatans. They can't, offer much in terms of mental health improvement. So in that way, where do you think the National Health Service or the services we currently have failed South Asian communities in providing them with the necessary mental health education or access to those services, and how can that be improved?
I think thanks very much for those. I mean, I think one of the major challenges, particularly for the NHS, and I've been banging on it about it for the last 20 years, that we need to get out of our comfort zone and we need to go where people are. We did a focus group study with Punjabi women in South Hall many years ago, where, as you know, that there's no word for depression in Punjabi or in Urdu or in Hindi, but all of the women recognized, and going back to the first question, and they recognized the symptoms and they recognized the causes, and it's about sort of domestic violence and alcohol and all that. But they all sort of said with a single voice that this is part of life's ups and downs. Why would I go and see a doctor? And if I go and see a doctor, the word would leak out and nobody would marry into the family, nobody would come and visit me. And I would rather go and see the imam or the gyani or the pujari in the temple. And that's absolutely where we should have clinics. That, we should be, sending our community psychiatric nurses there to try and sort of, and we did some training in South London many years ago with Black church leaders, and, making it very clear that these are the things, African and African Caribbean people, when they go to certain Pentecostal churches, they speak in tongues. Now, that's not a psychiatric disorder. It's just, the way of communicating. So we worked with them. We did sort of 12 sessions of teaching. So these are the things that you can deal with, and these are the things that we can deal with. So let's kind of try and keep that dialogue going. And most of the religious leaders and, peers are quite sensible, as long as they don't feel that their livelihood is threatened. They can, traverse various boundaries. So I think that's something that, NHS needs to get out of its comfort zone and go where the people are, where people need help, where it's less stigmatizing. So if you go to the mosque 5 times a day, nobody's going to say, why are you going 5 times a day? So it's perfectly sensible to have a community psychiatric nurse there, even if it's once a week. And if you're feeling distressed, you can just go and sort of have an informal chat without medicalizing it. And if, things get worse, you can then, go down a sort of formal pathway. Your second point about sort of, it's, particularly in India nowadays, people are beginning to talk about stress, and they're beginning to talk about counseling. 20 years ago, they never would have done that. So there is, with the urbanization, there is a shift to try and express that kind of distress and look at alternatives. I'm not sure, I've done various papers, so I'm not sure whether I'm going to do another chapter, but certainly, again, portrayal of mental illness in Bollywood films has changed over the last 20 years. It's kind of, apart from an occasional horrible film, there is a lot of sort of reasonably positive portrayal. So thanks very much for raising that, and good to hear about Professor Mubashir, who, as you know, sadly passed away last year.
Okay, thank you. So we'll just move over to Rakhee. Rakhee is our board chairperson as well, part of our festival team. So Rakhee, do you want to ask your question? Thank you.
Sure, thanks very much, Aman. Thank you very much, Dr. Bhugra, for a super thought-provoking conversation this afternoon. I just wanted to touch on support structures. Now, one thing that sort of struck me about the film in particular was the illustration of sort of good use, if you like, of support structure, and perhaps, you know, where support structure was lacking. So I thought in terms of the good, or rather positive, portrayal of support structure was in the role of the sister. And in fact, when I initially started watching the film, I'd sort of assumed that was Miti's mother, but actually it translated, of course, that when you did in fact see who the mother was, actually her sister had taken on an almost maternal role in sort of supporting her sister through her issues. And of course, I think quite clearly you see, you know, Miti in hospitalization, and you do see a sort of medical intervention. But where, for example, I thought the support structure was almost lacking was, for example, when you looked at her boyfriend, or at least her partner, that had come to the family home after 11 years to apologize to the mother for, you know, his seemingly being absent, or at least not having been able to support Miti in the right way. And also sort of just other aspects of, you know, what I would consider to be support or traditional areas of support, where you might be thinking of, say, for example, therapy or counselling. And unless I missed it in the film, I just didn't see that sort of translate very well. So I guess my key question for you, Dr. Bhugra, is, you know, what your perception is really of what you think is lacking in terms of support structures for those suffering from mental illness or mental health issues. And in particular, those sort of support structures that might be lacking for people in the South Asian community in particular.
I think, I mean, that's a very good point. I mean, one of the things, I mean, there wasn't any kind of professional support for the patient or the carers. I mean, you know, I mean, it was kind of slightly odd that psychiatrist suddenly appears in Bhutan and knocks on their door and say, here I am, when, you know, the kind of there's this party going on and they're all making fun of, you know, saint who heard voices. So, I mean, I think that may reflect the Indian healthcare system, where, you know, the kind of there's an acute shortage of nurses and there's acute shortage of those kind of support works. But having said that, in places like Chennai, there's Schizophrenia Research Foundation, which is a charity. They do quite a lot of work with volunteers. And there are other charities. There's Sneha, which kind of works like the Samaritans, and lots of sort of volunteers do support work. So I think it's partly a reflection of the resources. And it's also about, you know, quite often we get bogged down by formal support systems rather than informal care systems. And, you know, a lot of employers can be quite sympathetic. Lots of employers are very negative, and, you know, they wouldn't touch anybody who gives history of, you know, mental illness, because people with mental illness are violent and aggressive and, you know, unreliable and so on and so forth. So again, I mean, you know, not recognizing that we are not talking about a single mental illness. There's a range of illnesses, there's a range of responses, there's a range of treatments available and engagement. So I think one of my frustrations in this country is about that we now have a lot of people who are retired and who kind of, you know, we have a lot of human capital that we can utilize in engaging them as ambassadors and as workers going out to, you know, the community and the teams to try and support people. I mean, you don't need to be a psychiatrist to be able to do that. You just need to be aware as to what needs to be done and when to interfere and when not to, and when to step back. And again, you know, one of the comments that has come up is that not all religious leaders are from a qualified background. You don't need to be, but as long as you're aware of the pluses and minuses. And part of that is the formal healthcare's responsibility to reach out. And if the community can sort of, you know, make the voice heard and say, hey, we are willing to do this, but we need somebody to come out of your comfort zone and teach us, work with us, support us, engage with us, and that would make a lot of difference. So I think it's both formal and informal care and support that's needed. There used to be a time, particularly in the late 80s, if you were a carer and you were looking after a patient with chronic illness and you needed a break, the patient would be admitted to the hospital for a week or two so that you could go on holidays. And that's all been taken away because it costs. Of course it costs, but the challenge for all of us is that, if we were redesigning the National Health Service today, would we do it in the same way? And one of my sort of new projects is, what's medicine's social contract? So, what do we expect from patients and public? What does, patient and public, what do they expect from us? And what do we expect from the government in terms of, money, funding, resources? Is a kind of tripartite thing that we need to deal with. And we have to redesign services. Sorry, I've sort of gone on probably way beyond your point, but it's both informal and formal care that we need to take into account. And we just forget the informal care.
Thank you, Dr. Bhugra. I'm just going to take our last question because I'm just conscious that you've been kindly speaking for over an hour now. So I'll just go to Saman. Do you want to ask your question? Sorry, I know you've had your hand up for some time. Thank you, Saman.
Hi, thank you very much for such an interesting talk and the kind of review of the movie. I guess my question is more of a comment about how do you view things have changed over the last 10, 20 years in kind of depiction of mental illness in our culture? Because I think we've kind of come a long way. This film was made in 2005 and I was really impressed. I only watched it recently about, with the kind of, it's been really portrayed well, and the carer's role. Recently, I've been watching a Pakistani drama, which is showing a patient with schizophrenia. And again, even Pakistani dramas have come a long way because before there was hardly any discussion about mental illness in the media. But there is such a lack of understanding. That's what they're showing in the drama. And there's a lot of expressed emotion in the families and lack of understanding. But at least they're talking about it, which is really positive. So I'm just kind of thinking in those terms.
Yeah,
Sorry. Go on.
No, I think you're absolutely right. I mean, things have shifted. And as I was saying that, 20 years ago, 25 years ago in India, nobody would have talked about feeling depressed or whatever. You just kind of, kept quiet and did, and hopefully, came out of it. And then there was also, I remember having a discussion with some film directors and producers at a film festival in Chennai. And they were sort of saying that, look, we make films to make money. We don't make films for education. And that's true. And yet, you've got sort of films like Tare Zameen Par, which is, kind of taken a very different view and, have conveyed something. And, you have had, was it Black, with Amitabh Bachchan and Alzheimer's, and, Rani Mukherjee on the other hand, and similar kind of portrayals, which are much more sympathetic. But again, I think the challenge for all of us in a way is that more we talk about it, more we recognize it, and demand goes up, and we have to meet the demand. Because if we don't then meet the demand, it creates a much more sort of negative view of the health service and healthcare and so on and so forth. So it is about, it's certainly much more positive, but we have to sort of recognize that the constraints are that films are not educational materials, they're entertainment, and they are made to make money, and that's the reality. But also, I think one of the major changes in the last 20 years has been that, people have talked about it. The fact that, Deepika Padukone talked about her depression. And, there was a big sort of Twitter storm. What do you have to be depressed about? You got enough money. But, the fact that she talked about it, and, Monty Panesar talked about his problems, and other actors in India have talked about their problems, as have cricketers. And so that's got the sort of dialogue going in a way which says it can affect anyone. None of us is kind of above it, developing any illness, whether it's physical or mental. So therefore, that shift becomes quite important in the way we look at people with mental illnesses or with disabilities or with physical illnesses. And I remember sort of, 40 years ago, nobody talked about cancer at all. You kind of hushed up and you talked about C word, and, and now it's kind of, it's become a battle, and you become warriors who, deal with cancer at individual or community level. And I think that shift will happen towards mental illnesses as well.
Yeah, no, thank you. Even, I was just going to say, 20 years ago, when I went into psychiatry, I had my relatives who have got quite a lot of doctors in the family. They used to make fun of me. It's like, why do you want to do psychiatry? And now, recently, when I went to Pakistan, there's a different respect. So things have changed.
In my time when I chose psychiatry, there was generally, you must be crazy, and I haven't regretted for a nanosecond ever. I think it's the best decision I made.
Thank you.
Okay, thank you. I think that's all we've got time for today. I actually wanted to ask I had a page of questions actually ready as well, which I'll have to talk to you at another time. I just actually wanted to, just because I don't think we've discussed it, was just really one statement that I heard the psychiatrist say that shocked me, was about shock therapy and it having no side effects. So I just wanted to kind of make that comment, that is something I noticed, and and then it kind of cuts to the Gongana's character, and you can clearly see how disturbed she is, and actually him saying that shock therapy doesn't cause any side effects, I just thought was a bit of a not the right statement quite to make, I think, and you could just really see the impact. So I don't know if that was purposely put in there so that we are kind of made to think about that.
I mean, I think it's a difficult question to answer. I mean, I did notice that, but one of the quite often when patients ask me something and I said, look, everything has side effects.
Yeah.
Some more, some less. And it's, I've been spending time in the vaccination hub for the last 7 weeks. And, the vaccine hesitancy among South Asian communities, absolutely astonishing. Not, when I kind of talk about smallpox, many people haven't heard what smallpox was. And the fact that we've got rid of it because of vaccination, people forget. And so, it's kind of, it's an ongoing dialogue that, every medication has side effects. Some people get more, others less. And we don't know, who's going to have more side effects or not. But yes, you're absolutely right. ECT does have side effects, but it's one of the most effective treatments we have.
Yeah. Okay.
Sorry to disturb. I have a last question before we close up. Did shock therapy, what we were talking about, it still exist and still exist in UK, like all over the world?
Yeah. I mean, I think in Switzerland, only one of the 4 or 5 cantons can give it. It's not used very frequently, it's very rare, and there are kind of modified versions of, it's been kind of now called, you give ECT, but there's also TMS, transmagnetic stimulation, which works on the similar principle, which is said to have, less side effects, but the indications for ECT are much narrower now than they used to be 50 years ago.
Okay, seems very scary though, if you see that.
Well, if I ever get psychotically depressed, that's what I want.
Oh, is it? But do you think it's really effective?
Yes.
It is. All right. Okay.
That would be my treatment of choice if I become psychotically depressed. Everybody around me knows that.
Thank you. Okay, so thank you so much. And I think, you know, one thing we're definitely sure of is that this topic does need more open discussion, especially in the South Asian communities. And it's been great to have you on our platform. Pushpinder, did you want to make any closing comments before we end the meeting today?
I'd just like to thank everybody for coming. It's been amazingly interesting. Thank you so much. We are planning to do a conference on mental health. So that'll be next month. So we hope that a lot more people would join it. It will be virtual. Unfortunately, we're still waiting on getting out of this lockdown. So thank you very much, Dr. Bhugra, and everybody else to give their Saturday afternoon to this very important.
My pleasure. Thank you very much for inviting me.
It's an absolute honor. Thank you so much.
But see you next month.
Bye.